Good evening. Welcome to this breakout session from the TIO meeting. This is focused on IVUS, from IVUS Saves Lives, from Data to Practice. And I'm joined with a fantastic faculty to explore this topic and to give you a little introduction to what else we have in store. So with no further ado, let's introduce them. Francis Joshi from the Golden Jubilee Hospital in Glasgow, Mirvat Alasnag from Jeddah in Saudi Arabia, and of course, one of our other hosts, Joost Daemen from the Thorax Center in Rotterdam. Welcome all.
Thank you.
So we can get the agenda slide up. We'll have a look at what we're going to explore today. So after this brief introduction, we've got three great talks from Francis, who's going to tell us about the role of IVUS in left main PCI. Then we're going to hear from Joost about the steps, especially the IVUS 1, 2, 3 steps in left main stenting. And then Mirvat's going to take us through the data. And I think underpinning this whole enterprise is an introduction to Left Main Academy. And you might ask, well, what's that? And that's an educational endeavor sponsored by Boston Scientific, which gives you resource material to go to when you've got questions, you want to understand why are left main PCI important. How can I approach a left main? How can I assess a left main? How can I use imaging to guide my practice? And how can I enrich my educational experience? And we'll show you throughout the meeting today links. As you can see in the top right of the screen, there's a link to that learning resource, and it'll grow over time to be a complete learning resource to deal with all your left main problems. So that's a very exciting initiative, which we were delighted in Optima to partner with Boston. And I would definitely encourage you to deep dive in that and have a look. So with no further ado, let's move on to the first talk. It's a pleasure to introduce Francis Joshi from the Golden Jubilee Hospital in Glasgow. And Francis is going to talk to us about the role of IVUS in left main PCI. Francis, over to you.
Great. Thank you, James, for the introduction. I suppose if we're talking about left main PCI and the left main itself, the left main we all recognize is special. And that might sound obvious, but there's a few things that become increasingly relevant when you think about the role of IVUS in the PCI we perform in the left main. It's a big vessel. It almost always supplies a large mass of myocardium, up to 85% in some patients. It very, very often will involve an important bifurcation where loss of the side branch would be catastrophic. And it's the only bifurcation that comes anywhere near the aortosteum. And that has two consequences. One, there's a potential for interaction between the guiding catheter and the stents we implant. And the second is that the nature of the disease we're treating potentially also changes because of that anatomic relationship to the aorta. So how can IVUS tell us something about the left main? What we want to do is we want to know what we're treating so that we can have a plan, work through that plan, and then get the best possible result for the patient. So the use of IVUS gives you that information and isn't dependent on clearing blood from the field being imaged. It gives you an assessment of the distribution of plaque that you're going to treat, especially in relation to the important side branch, which is usually the circumflex. It allows you to size the vessel accurately, and that helps you plan both your preparation and your ultimate stent implantation strategies. And it allows you to characterize the plaque that you're going to treat so that you can select appropriate tools for plaque modification. Now, why should we care? For a long time, angiography has been the gold standard, and we have more or less guesstimated the size of vessels we're treating. We, I suppose, have assumed that our procedural experience gives us some greater accuracy in our guesstimation, but in fact, there's no evidence to suggest that's true. You might look at this left main and the left panel and say, well, it's a 5 millimeter left main. You image it, you find out it's 6.3 millimeters, and that has significant consequences for your strategy and ultimately the stent platform you might choose to use that would allow you to expand and oppose a stent in the left main. I think we've known that for a while, but I think there's been more recent focus on the fact that angiography systematically underestimates the amount of calcium. If we want to deliver good, durable results for our patients, it's really important that we understand the degree of calcification in the artery, because that's the #1 impediment to good stent expansion. Again, you might eyeball this left main and say, well, there's not too much calcium there. Then you image it and find out that there's near circumferential calcium at the ostium of the LAD and very complex circumferential calcium at the ostium of the circumflex, which again is often the Achilles heel of bifurcation left main PCI. So if we're going to get a good result for our patient, do a good job, we need to understand what we're treating. And IVUS really allows us to understand that in great detail. So we proceed. We prepare our lesion, we implant a stent, perhaps from the left main into the LAD, and then we want to wire the circumflex. Well, IVUS can really help us reduce the short-term procedural hazard. In the left-hand panel, there's a stent implanted in the left main, well opposed, and then in the top left of the image, you can see a wire that's certainly not intraluminal, is abluminal and in the wall of something, certainly not where you would want it to be. And passing balloons and equipment on that wire without understanding the relationship between wires and the stent you've implanted could, of course, be catastrophic. In the right-hand panel, we see something that's very particular to the left main, and that highlights the importance of the potential for interaction between the guiding catheter and the stent. Longitudinal stent deformation, highlighted in the right-hand panel, is associated with very poor outcomes, and it's really important that that's corrected before the patient leaves the table, and certainly before you start inserting more wires and making a bad situation worse. Is the patient safe to leave the table at the end of the case? In the left-hand panel, a well-implanted stent, well opposed, but at its distal edge, a dissection. Involvement of the media, an intramural hematoma, and whilst there may be flow, letting that patient off the table puts them at risk of re-occlusion of vessel and significant harm. And in the right-hand panel too, a grossly underexpanded stent in a calcific plaque in the left main. Leaving these sorts of results untreated put the patient at significant short-term risk. But also, as I think we understand more and more, at risk of a less durable result in the long term. These data are from the Excel study where IVUS was used in 77% of cases, not mandated and not used systematically in the way that perhaps we would today. Nevertheless, there's a very clear relationship between the minimal stent area by tertile and MACE and the risk of definite and probable stent thromboses. Achieving a stent area in the largest tertile, in this case greater than 13 square millimeters, was associated with very good outcomes in terms of MACE at 3 years and a 0% risk of definite or probable stent thrombosis. So if we're going to do a job, we need to do it well, and finally document the quality of result we've given the patient. In summary, I think IVUS in left main PCI really allows us to understand what we're doing. It allows for accurate vessel sizing. It improves procedural planning because we understand the nature of the disease we're treating, so we can select appropriate tools to modify calcium and appropriate stents to achieve good minimal stent areas. It can increase the safety of the procedure, and it helps us achieve durable results for our patients. Thank you.
Great job, Francis. That was really concise and clear. And I guess we should mention for the audience that the goal today is to give people a little insight to all the material that is waiting for them if they follow the link. So you contributed quite a bit to that. Where do you think the value lies? If you were, talking to our audience today, why'd you put in all those hours? Was it a complete waste of time, or?
No, I mean,
do you think there's a?
No, I firmly believe that we all want to do a good job for our patients. And I think it's that acceptance and understanding that what's been done previously often hasn't been as optimal as it could be. And I think if you really want to get the value out of IVUS, in a way, it's the use of the IVUS before you implant stents. And I think that's something that's not come out of the studies, but really that understanding of what you're going into before you do it seems to me to make the biggest difference. You understand the balloon, the calcium, the stents you're ultimately going to implant, your bifurcation strategy if you want to put in a second stent. I think the IVUS really, really prepares you for the case you're about to undertake. And I think that really improves both the efficiency and I think the long-term results for the patients too.
And I guess the key word here, Mirvat, is understanding. And we've seen from some of the bigger imaging studies recently, notably Illumium, that information that we can't process isn't always actionable information. So where do you think the challenges lie with IVUS? Is it an easy technology to use? How much work do you have to put in to get proficient at it?
I don't think you have to put a lot of effort with intravascular ultrasound. And remember, it's not just the operator, it's the whole team in the cath lab. So to get your team facile in the connections and just setting up the intravascular ultrasound and getting all the buttonology down, it's fairly easy, but it does require repetition. And so that is what I would say is just labs need to do it more frequently when it matters and when it doesn't matter, so that when you really need intravascular ultrasound, you and your team are up to speed to how it needs to be done and doesn't add a whole lot.
So you don't want to do it every 10th case. It needs to be part of your regular practice so it feels normal. Is that fair to say?
Yes, absolutely.
Okay, well, I mean, there's nobody more facile and familiar with IVUS than Joost Daemen, and it's a pleasure to ask Joost to present his walkthrough on how to use IVUS to get the best out of left main PCI. Joost.
Thank you, James, for the kind introduction. So what I will try to do in the next couple of minutes to take you through a simple step-by-step algorithm that will help you to facilitate each PCI, left main in particular, but in principle, this algorithm applies to any type of anatomy and any type of lesion that you want to tackle. So basically, this is the key thing in order to get the best out of the imaging guided PCI you may want to do. This counts both for IVUS as well as OCT. The use of an imaging catheter by itself does not improve outcome. You need to use it in a proper way. You need to know how to interpret the images, and you need to know how to react to it. And all of each of these individual steps take a little bit of time and training to get used to it, and to get you to get the most out of it. So the three things that are critical is you do your imaging pre-PCI, pre-stent, and post-PCI. Don't just think, post-PCI pullback is sufficient. No, it's not. I will show you why. And the same counts, just do the pre-PCI imaging, stent sizing, and done. That's not what you want to do, and I will show you why in the next couple of slides. I will do that with a very simple example of a 72-year-old diabetic male that presented to us with a distal left main ostial circumflex lesion. This is just a random example, but I think the algorithm that I will show you applies to each type of left main bifurcation, Medina class anatomy that you may encounter. And then you just need to follow three simple steps. First is you check how long the lesion is that you want to cover. You look at the morphology, and then finally you look at the stent size that is required to cover the lesion. Basically, all these three steps apply to each pullback you make. Well, in this case, we started with a pre-PCI pullback, and that is critical. Before you touch the patient, before you pre-dilate anything, you do your pre-PCI pullback. So here a pullback from the left main to the ostium of the, from the circumflex to the ostium of the left main. Distal reference lumen area 17.4, so this is a huge vessel, 4 in caliber. Here you see the ostium of the circumflex, not appreciated on the angiography, but on IVUS, a napkin ring of calcium. clearly visible, a wide bright shadow, acoustic shadowing, 360 degrees. But what is also apparent on the IVUS is you see the ostium of the LAD, really in line with what you see on the angio, a very nice and patent ostium of the left main. So this already tells you something about the strategy you may want to follow. However, you see a clear calcification at the ostium of the circumflex that obviously could move once you start maneuvering. At this stage, no point in proceeding with stenting, sizing, and so on. You know what you want to know. You see this lesion, which is very tight, complex, calcified. This is where you need to decide what to do. You want to do a balloon, a rotoblader, or an orbital. You want to do a cutting balloon. In this case, we decided to take a Wolverine, a 3.5 Wolverine balloon. Here you see the different pre and post Wolverine. You see a minimum lumen area of 3.5. Post Wolverine, it went up to 5.6. And what you can appreciate at 3 o'clock and 5 o'clock is that you see this spots of signal or ultrasound penetration, which makes you suggest, along with the increase in lumen area, that you at least modified the calcium in some way that you could decide to proceed with stenting here. And then you go again back to the 1, 2, 3 essentials. In this case, you modified the lesion, and now it's time to look for a stent size. Stent size is actually quite simple. You take a distal reference, you take a proximal reference, and you measure the length. Well, that sounds obvious, but what is the most common mistake in imaging-guided PCI, and in my belief in imaging and PCI in general, is that we do not pick our landing zones appropriately. 50% of the stents that we implant in routine practice land in an area with a plug burden above 50%. This here is a beautiful example, and for those who just watched the orbital case of Nicolas and Wijnand just a couple of minutes ago, the exact same discussion, stent area almost 10 square millimeter, and then the stent lands in an area with a lumen area of 3.7. This is an example like that. Lumen is perhaps quite appropriate, about 3 millimeters. But if you would measure this, you would measure a lumen area of 7.1, but the vessel area conversely is 22, meaning that the plug burden at this side is 68%. So this is not an area where you want to land your stent. So that is critical. Obviously, in some cases, there is no healthy reference, but in most patients, you will be able to find a spot with the plug burden less than 50%. And basically, that's the most common predictor of stent failure in a lot of IVUS trials that we've done. Back to our case, we start distally. On the left side, a reference area here, 4.1 times 5.2, plug burden 35%. That is adequate. Proximally, this is at the ostium of the left main. You see the left main is 4.7 times 6.2, big left main. And we already identified here a length of 13.6. So with that, we felt good to go, and we picked a stent with a proper expansion profile, proper radial strength. We took a 5016 Megatron and post-dilated with a 6 millimeter non-compliant balloon. So need for pullbacks in between, no need for contrast shots, because you've seen that the flow distal is good. There are no huge dissections. So from that perspective, you're safe. We implanted the stent, and now it's time for the third pullback, the post-PCI pullback. Again, 3 essential steps. Look for geographic miss. So basically, that's to assess the plug burden at the edges, the most important item in the post-PCI pullback. Then you check for malposition along the way, and you check for stent expansion. So let's go back to our case. We did the post-PCI pullback. We start always from distal and we go to proximal. Distal edge looks very nice, no edge dissections. Lumen area here, enormous. So this is a case in which the distal edge is fine. Here, we measured the plug burden, 46%. So here, this is a beautiful example and how we see that we typically tend to underestimate the plug volume at the size or at the reference site. This looks actually quite okay, but yet still the plug burden is 46%. So be meticulous here. In this case, 46% was considered adequate. Then you find your side of the minimal stent area. You can just do that visually. You scroll through the pullback and you find the spot, and the longitudinal view may help you in that, to find the spot where the stent area to the lumen area, the stent area in the stented segment is the smallest. In our case, with this 5.0 stent, that was 16. So with that, you know your expansion is appropriate. No need to do further measurements. Then you find the proximal edge in which we were able to identify the stent was exactly at the ostium of the left main, no malposition observed. So with that, we were happy. So in this case, we proceeded, but before we were done, the angio looked excellent. So are we done? Well, there is one more step left. Ostium of the LED has not been assessed. So in that case, we rewired the LED, we did a pullback, angiographically looked beautiful, but what we saw in the IVUS is that the chunk of calcium from the ostium of the circumflex protruded into the ostium, into the carina. Here you can nicely see that. You see the chunk of calcium into the ostium of the LED, which made us decide to post-dilate with kissing balloons. And then again, after each step, you repeat the imaging. And here you can appreciate in the final pullback from the LED to the left main here that the bifurcation is now nice and patent. Here on the top right, you see the ostium of the circumflex, the stent coming in with a beautiful result. So with that, I would like to conclude with the final statement. If the slide is moving. That a standardized IVUS 1 to 3 approach facilitates PCI and improves outcome. Thank you.
That was great, Joost. That was very, very clear. Couple of questions. First, a comment, I guess, that when we compare intravascular imaging and we're in the category that we think any form of intravascular imaging is better than no intravascular imaging. But sometimes the pushback with respect to IVUS is that it's not automated enough. You have to kind of go looking for the data, and sometimes it's not obvious enough. So it may well be that the AI-driven AVVIGO software will address some of those limitations. Have you had any experience with that, Joost?
Yeah, that's a good point, James. So people who are used to multiple imaging modalities know that there is a diversity in the kind of AI that is embedded into the systems. Initially in the Boston systems, it was limited, but now with the AVVIGO Plus, it has been launched in the US and will come to Europe. Hopefully we will have it in Rotterdam somewhere next week. We'll have this embedded ALA algorithm that will help you to do some of these measurements fully automated. That will help. But conversely, what I always try to teach people is these imaging modalities are an add-on to what you're used to doing. So you look at the patient first, then you have your angiogram, and you use your imaging to further tailor down and guide the procedure. You need to keep thinking. If the system, and I had that with OCT multiple times, small distal area, small diseased vessel, a TRIO stent, minimal stent area 4.0. People would say, but distally the reference is 3.9. So I have a 120% expansion. That is amazing. Well, actually it's not, because you need to keep thinking. A TRIO stent needs to have, if it's appropriately expanded, a stent area of at least 7. So if you're not able to use your common sense to interpret the figures, these imaging modalities will not help you. And if you are at the level in which you can clearly appreciate that what you're looking at is adequate, for instance, in the case that just presented, minimal stent area 16, yeah, if that is what you have, there is not a single reason to measure stent expansion, because we know that this is far above what we consider appropriate. What is important, and that's one of the questions in the chat I see popping up, how do you measure plaque burden? I think that is something in which there is a huge benefit of IVUS as compared to the OCT case, for instance, we just observed at the live case in TIO a few minutes ago. In IVUS, by simply clicking a trace assist button, the system will automatically, already with the current version of the software, identify the lumen and vessel contour and will provide you with the plaque burden. So that's a big advantage of IVUS. If you have a lot of plaque, you will get your plaque burden. You will see not just the lumen size, but also the vessel size, which will get you this figure called plaque burden. On OCT,
looking slightly,
you don't see the media, you cannot tell.
I'm looking slightly smug here, just because we've had AVVIGO for a few weeks. And I have to say the vessel tracking is really very good. I used to find the trace assist really pretty inaccurate. You'd have to draw it out quite frequently, but it really is very good tracking. So if we just come on to Francis, can I ask you a question? Because the reason we have these educational events is to try and address some of the barriers. And we're sort of talking to the converted here. Everybody on this event is very enthusiastic. They can see the value of imaging, but yet we still face the majority of our colleagues who don't use imaging. So what is the commonest pushback you hear, and what would your response to that be?
Yeah, I think that's a really good question. I think the learning curve with the IVUS imaging itself is relatively short, and I don't think that is a big issue once people get started. I think that the biggest thing, I think, in a kind of, from a kind of overall cath lab perspective, is people say, well, you're imaging and it all just takes longer. Imaging up front, imaging along the way, imaging at the end, you're using up valuable cath lab time that could be used for other things. And I think my own experience is completely the opposite. That initial IVUS run that gives you information really helps the efficiency of the procedure. And I think the additional runs down the way don't need to take very long. Some of them you can do on manual pullbacks, and with AVVIGO, there's of course the ability to do more rapid pullbacks, in an automated fashion.
Very quick.
And I think it's that procedural efficiency that you really gain. But that's, I think, a real misunderstanding that's out there about the use of imaging generally. People don't believe that it improves efficiency, but it does.
You ever hear patients complaining, doctor, you took 10 minutes longer. I wish you hadn't measured my stent. Just chuck it in. What's the worst can happen? Not very often.
One.
No, I didn't think so. So listen, Mirvat, if we're trying to close this gap, this kind of belief gap, if you like, because it does seem like a belief system out there, what do you think the role of education is in that? How do you think we need to orientate to address some of these held beliefs that we don't agree with?
We probably need to start early. So we start with folks who are still in training, because when they graduate and go into practice, they really start to understand the value of intracoronary imaging. And I find that folks who are initially reluctant to use intracoronary imaging, when they start to actually use it more frequently, they realize they start to get less confident doing it without it. It's almost like trying to do a PCI semi-blind. And I think that's kind of what we need to do, ingrain it in the fellows who are still in training.
Good stuff. Listen, and of course, one of those things, one of the key points that underpin any argument is the data. So this is a good juncture to move on to your talk, Mirvat. Are you going to talk to us about, well, does IVUS really save lives? Where's the evidence?
Absolutely. Well, thank you for having me. And, I'm a bit disappointed because when I got this talk, I was thinking maybe I'll get the whole 45 minutes to myself because there's just plenty of evidence. And then in hindsight, I figured, well, there's so much evidence. Do I really need all this time? And maybe it's just one slide suffices to tell folks it's 2024. We don't really need to be discussing where is the evidence. It's there. It's been glaringly in front of us. And the previous talk was very elegant. We saw exactly cases like this when we all do these cases in the cath lab where you have a true bifurcation of the distal left main and you want to get landing zones and appropriate sizing without any kind of guesswork. And then when we're done, we really want to make sure that we're completely optimized. We've covered the ostium and, we're happy with the carina and so on. But, just to behave, I went ahead and restructured this talk to look at the evidence in 2024, looking at randomized data, looking at some sub-analysis of randomized data, and then some observational data. James, you mentioned the Illumian trial. I know you're referring to Illumian 4, but Illumian 3, and although it really was directed towards non-complex lesions, I venture to say left main are perhaps non-complex because they're bigger, they're easier to identify, lumen and lamina and so on. But in any case, this is the foundation for the rest of my presentation, really what intracoronary imaging is. When you look at both IVUS and OCT in Illumian 3, what you do see here is that, we talk about the time, but the penalty of time here was only 10 to 15 minutes. And if you look, about 3 rows above from the bottom, you see that the procedure time in IVUS and OCT was really a little more than angiography, just more than in 10, 15 minutes. But you actually see better stent expansion, more dilatation. Again, if you look higher up in this graph, that's what you actually see. And it translated into better stent expansion and less unacceptable procedural success in these cases when you're looking at intracoronary imaging, whether IVUS or OCT compared with angiography alone. But then we move on to the ultimate IVUS trial. And this trial is really the one trial that had us all speaking the same language. So finally, there are criteria that we all acknowledge, and it's not just guesswork. Is it 50%, not 50%? So we're looking at a minimum lumen area of the stent segment more than 5 millimeters squared, or 90% of the minimum lumen area in the distal reference. You want a plaque burden of less than 50%. And you want no edge dissections and definitely not exceeding the media at a length less than 3 millimeters. Those were the criteria. And when we look at target vessel failure at 3 years in the ultimate trial, and we look at angiography compared with intravascular ultrasound, you see 10.7% compared with 6.6%. And likewise, there was less stent thromboses in the arm that received intravascular ultrasound. And over 50% of these patients actually had left main disease. The next trial is the Renovate Complex PCI. Again, this was already published last year, and we see a 36% reduction, relative risk reduction in the primary endpoint, which was cardiac death, target vessel revascularization that was clinically driven, and target vessel myocardial infarctions. Again, significant reduction in the image guided compared with angiography guided, and this was at 2 years. Once again, IVUS XPL reconfirms these findings. When you look at 1 to 5 years, you see 2.8 compared with 5.2%. But then as you go to 5 years, you start to see the difference widening, almost doubling 5.6% and 10.7% in terms of death, myocardial infarction, and stroke in patients who had IVUS-guided PCI compared with angiography alone. So let's look at some relevant sub-studies of randomized trials. Now, the left main trials that we all remember, of course, is the XL trial that basically noted that there was similar outcomes in percutaneous revascularization of patients who had low and intermediate lesions of the left main compared with coronary artery bypass grafting. But what we do see in the sub-study, IVUS sub-study, is that those who had a small minimum stent area, it was almost 20% was the MACE rate. But when you actually look at the larger MSA that was achieved, it was less than 10%. So there was a significant reduction based on intravascular ultrasound that honestly, we really can't be ignoring. The next main trial that was done, and before I go to the next trial, is actually looking at the XL and how did they achieve that? Well, those 52% did have intravascular ultrasound. Of those, it did change how they actually treated the patient. So stent optimization happened at 76% based on IVUS. 11% went from provisional rather than a planned 2-stent strategy. And 9% ended up getting a 2-stent strategy rather than a planned provisional strategy based on intravascular imaging. So it really did change how these patients were treated. The next is, of course, the Noble study that really showed no impact in terms of mortality, but in the PCI arm, there was more revascularization and there was more non-procedural related myocardial infarctions. But when the sub-study of intravascular ultrasound published in Noble, and I think those were probably the most intriguing results, is actually when you look at IVUS compared with angio, you see that left main target lesion revascularization was actually significantly lower in the IVUS arm, and the minimum stent area was actually bigger in the IVUS arm compared with angiography. And that prompts us to think more carefully, particularly in left main vessels. Moving on to some of the observational data, we see a lot of consistency in these trials. So Fassa and colleagues in 2005, so look at this, we're talking about 19 years ago. Deferral of revascularization in patients who had an MLA of less than 7.5% and looking at long-term outcomes. And here you're looking at around 7 years. So you have sustained results. If you look at the red bar, the red line, you see less than 7.5 and deferred revascularization actually had more event rates compared with just above it when they had more than 7.5, the minimum lumen area and deferred stenting. These results were again repeated in the main compare, which was observational. And when you see, around 2-3 years, you start to see the divergence, significant divergence, 16% in angiography alone and 4.7% in IVUS guidance in terms of mortality. If you move on to De La Torre and colleagues who published in JACC in 2014, again, you see survival reduction benefit in terms of IVUS guidance compared with angiography alone. That was all-cause death. And again, when you look at stent thrombosis, again from the same publication, significant difference in terms of IVUS and angiography for left main patients who underwent IVUS. But what's missing? So one of the trials is the optimal trial that we need to keep an eye on. 800 patients, they're going to be randomized to IVUS guided versus angiography guided. The pre-PCI or baseline imaging is not going to be a requirement, but it is mandated that post-PCI, they undergo intravascular ultrasound, and they're going to look at outcomes at 2 years in terms of hard endpoints, such as the ones that I just showed you. I think it would also be important for us to start looking at different geographies and looking at different ethnicities, women, and so on, because so far we still don't have enough reference diameters for non-Caucasians, for women, and small BSAs and so on. But I think the data is fairly glaring, and turn it back to you, James.
Mirvat, that's great. Of course, the kind of whole drive behind this session is to try and up-titrate the education around left main PCI and so on. So Joost, if I came to you on that, can I ask you first of all, when you have your MDT discussions, is there general agreement as to mode of revascularization versus medical therapy, or is it just a complete free-for-all every time?
Well, no, I think most patients, specifically the more complex ones, are discussed within the heart team, and we make a strategy upfront. Initially, it was just like the surgeons do their graft right. You do a PCI of the right and the LAD, and that's it. But now it's more and more over that the heart team already indicates, okay, we're going to treat the right, we're going to reassess the circumflex with either imaging or physiology. We're going to do the LAD with this type of procedure, for instance, a high-risk case in which we may want to consider Impella, and all these things are now already part of the heart team decision making, also with the surgeons. So they're taking a long way into this process, and they even refer patients for IVUS assessments of ostial left mains and so on. So these type of modalities, I would say, are getting more and more routine, at least in our institution.
Yeah, I think sometimes that's a danger, because obviously, you work in a slightly enlightened environment, just where you're right at the cutting edge of what's happening in terms of innovation, but also research and education. And I think that is a great environment to work in, because people don't see it as a competition. Francis, not suggesting you don't work in an enlightened environment, but if you were to highlight where are the learning needs in left main education, where would you spotlight?
Yeah, I think the imaging is the key, because I think, we know from the randomized studies of, surgery versus PCI for left main disease, in patients who don't have a lot of complex disease elsewhere, we know that PCI is a safe, durable option for these patients. And I think generally speaking, in our team discussions, patients who don't have complex disease elsewhere, really we're thinking, well, why not PCI? PCI, tends to be the first choice for these patients. I think we have more confidence with these patients in saying, look, even the studies done as they were, we're, I think, confident that we can achieve better results than were achieved in those studies, because the studies didn't mandate or use IVUS in the way that we're using today. And I think we've got every reason to believe that we're giving patients safe, durable treatments. And so imaging is the key to that. We can't be doing bad left main PCI. We've got to offer revascularization that's every bit as good as the surgeons, if not better.
Yeah, and I guess from the data, what we can say that if we get a good result in imaging, we don't completely guarantee a durable result, but we get pretty close to it. So whereas if you don't have any imaging, then you're back to the old finger in the wind and it looks pretty good to me type stuff, which we know is not the way forward. So Mirvat, if we're trying to look at how education can narrow that proficiency gap, do you think there's a role in that to kind of some sort of credentialing process that cardiologists should go through so they're good to go and say one of your relatives had a left main? How would you know that they know what they're talking about and they can execute a plan to get a good outcome for your relative?
I think we need to go back to the fellowship training and the basic requirements. It is a little bit disappointing that the American College of Cardiology's basic requirements have actually brought down the total number of PCIs and hence the total number of intracoronary imaging, and remains a little bit vague. And in most places it's that way too. It's fairly vague. I do think we need to step it up, and those who are in positions of certification, credentialing, verification, and so on, really need to understand the evidence, because this is not just, an individual person's preference. It's not what you and I prefer. We just went over the evidence. The evidence is fairly concrete, and a lot of the boards now do have a lot of imaging questions in them. So, but unfortunately, after the board exam, these don't translate into practice and into credentialing and of operators.
Yeah, and that's very frustrating. And I guess that leaves me with the final question, Joost. How do we shift that needle to imaging is preferred to imaging is mandated?
And that's the critical question, James. I mean, we're now 9 to 10 randomized controlled trials advanced, so to say. Now, recently, ESC last year, the most recent meta-analysis, I just posted that in the chat. All-cause mortality reduced by the use of imaging by 25%. I mean, there are not so many things we do in medicine that reduce all-cause death with 25%. So that, to me, closes the chapter. The only thing that is lacking is stronger guideline recommendations on the use of imaging. And I'm pretty certain that in the next US as well as European guidelines, there will be a stronger recommendation for the use of imaging, specifically for complex PCI.
Let's hope so. And I think now is a good time to thank everybody for your fantastic contributions. Thank Boston for the support. For those of you who've tuned in, please do visit the Left Main Academy. And as you've heard from all the great talks today, this is important stuff. This is not stuff you can hope to get right. There is a way through these complex disease to get a great outcome for your patients. So it's free to access. Why not spend a bit of time and deep dive into the resource that we've all spent a lot of time to create? So thank you for your time and attention. Thanks to Radcliffe for hosting and Boston Scientific for supporting. Thanks, everyone.
Thank you.